Hello. Right. It is great to see you. I am going to jump right into this one. The topic that I chose for today was the diabetes. Right? I figured as I've been doing these and starting to just work through the kind of various illnesses, medical complications, traumatic stuff that's coming soon too. Is I really wanted to start with, the most important, kind of the more critical topics, the more commonly asked about topics. So that's why we started out with some of our cardiac stuff, the stroke stuff, this week doing diabetes. Like I said, we have to kind of venture into some trauma stuff, some pediatric stuff, obstetrics. So all of those other topics, they're coming. Right? We're just kind of slowly working our way through. But as we've been in the kind of medical section of all of this, the big emphasis and everything for this, initially has been, again, the kind of big five, big three, big five calls that we run all the time. The chest pain patient, difficulty breathing, so we got to do some more respiratory, diabetic emergencies, abdominal pain complaints. Those are just some of the, and then altered mental status, so things like stroke. Those are just more often questions that we see asked about to really kind of make sure that we especially know the really, common disease processes like diabetes, as opposed to maybe some of the more rare and more unique, patient populations and everything. So like I said, getting right into it. Diabetes, diabetes mellitus, or DM, you'll see the abbreviation DM. What is it? It's a disorder of glucose metabolism. Sometimes you may hear them say it as a disorder or an impairment or an issue with carbohydrate metabolism. Right? Carbohydrates, just referencing our sugars. Glucose is the main sugar that we're talking about. So if you ever see that, a disorder of glucose metabolism or disorder of carbohydrate metabolism. Again, it's one that you generally, when we're looking at these, and I certainly know on the testing side of things, make sure you read the answers carefully if there's asking you kind of a general question about what is diabetes. A lot of people might see the magic word sugar and they just jump at it, right? Or insulin, they just jump at it. Right? But really slow down, make sure you read it, and make sure that you're actually understanding that it's an issue with the body's use of that sugar. Right, there's sugar in the system. There may or may not be any insulin in the system, and we'll kind of get into those different types of diabetes. But at its core, it's the body's inability to utilize or metabolize, actually use the sugar that's in the system. Right? And so heavily dictated by our pancreas, which is kind of lit up there on that picture is the pancreas. Right? Pancreas is the main one. Okay. So kind of starting off, right, we say if it's an issue with the body's ability to use blood sugar, then we have to ask ourselves, well, how does the body use blood sugar, right, or blood glucose? Right? Kind of use them interchangeably. So blood sugar, blood glucose. So the big part, obviously, we have some different components. Right? We have the glucose in the system, and we have insulin in the system. And those are the main two, right? There's other components that we'll talk about that factor into the body's ability to use appropriate amounts of blood sugar or not use appropriate amounts of blood sugar. But insulin gets made by the pancreas. Right? And a lot of people use like the lock and the door method or kind of analogy for insulin. Right? And so insulin is really the lock that is opening the door for that sugar to actually get into the cell. Right? So if we were looking at this picture and we said this is outside the cell and this is inside the cell, and for the sake of argument, let's say these little blue guys there is sugar, right, or glucose. And so we have to have a method or a mechanism in the body to get that sugar from outside the cell to the inside of the cell. Right? And that substance, that that assistance process is the insulin. And so we have this insulin that our pancreas makes that's also floating around inside the body. And the insulin, what happens is we have little insulin receptors, right, that are on the surface of cells, and these insulin receptors. And we have this insulin that's floating around in the bloodstream. And let's just go ahead and say these little square ones are insulin. And when that insulin binds to one of those insulin receptors, these doorways open up, right? And it allows the sugar to get into the cell. Okay? So when you don't have the insulin and it doesn't bind to that receptor, then these doorways stay closed. And so insulin, again, is the lock, or is the key, right? The key to opening the door, right? The door are these little membrane channels, right? These little membrane channels that open and close to allow stuff to move into or out of the cell, depending on what they're kind of specific for. And so these ones, insulin comes around, unlocks that door opens up, and that sugar is now able to get inside the cell. And the sugar, in addition to oxygen and an appropriate temperature, is what the cells need to actually stay alive. Right? So every individual little cell throughout the entire body needs the oxygen, and it needs the sugar, right, to make energy. Right? So if we can't get the sugar into the cell, then that whole cellular metabolism cycle that's actually responsible for making energy, and making energy keeps that cell alive so it can keep living and doing the things that it needs to do. If we don't have sugar, it's not going to make any energy, and that cell is going to eventually start to die. Same thing like cells if they're deprived of oxygen. Right? Without that oxygen, they can't make enough energy, right? Or at least not enough energy long enough, and that cell will eventually start to die. And so it's the same with sugar. That's why our body is so sensitive to these sugar imbalances, right? These blood sugar problems. So again, one last time, insulin is the key, right? Opens the door in the membrane and allows that sugar, that glucose, to actually move inside. Without that insulin, sugar is stuck outside the cell, and that cell is going to start to die. Right? It's not going to be able to make enough energy to stay alive. Right? And that really kind of in a nutshell becomes what we'll really be talking about with diabetes is this ability or inability to actually regulate those blood sugar levels, and the ability for those cells to actually utilize that sugar, right, by actually getting it into the inside of the cell. And the sugar molecules, these glucose, right, as an actual kind of molecular structure, it's too big to just move into the cell on its own, right? It needs that help. It needs that insulin to open that door, which is big enough to allow the sugar to move through. And so these little sugar particles, they can't just weasel their way through, the cell membrane, right? Cell membranes are pretty good at keeping stuff outside the cell that I think should be outside the cell, and keep stuff inside the cell that I think should be inside the cell. Some things can move across that cell membrane very easily. Others can't for a number of reasons. And one of that reasons is the actual molecular structure is too big. Right? So with sugar, with glucose, it's actually too big. So it needs these bigger channels, right? These bigger doors here to actually open up so that glucose can move into the cell. Okay. And so that kind of, begs the question is, how does the body regulate blood sugar levels? Right? We know everything inside the body is that homeostasis, mechanism of making these little adjustments based off of what's going on in the body, trying to just keep everything in a happy, healthy range that we would like to be. Right? Nothing in our body is just completely static and flat at any given time, unless we're dead, right? But all the rest of the time, right, as it gets a little bit hotter outside, our body starts to sense that and make some adaptations to cool itself off. If it's too cold, it does some things to try to warm itself up. If we're a little bit hypoxic, it does these things. If we've got too much of this other thing, it does this, right? So it's constant little adjustments that the body is making to try to make sure that everything is getting enough perfusion, right? And it goes into 2 weeks ago, I think we talked shock, right? And so it goes into the shock stuff, is all these homeostasis adjustments that our body is making to keep everything in a range of not too much, not too little, just right. And so everything has that little window. And so we already said one system that our body has is the production of that insulin. Okay? And the insulin is made by the pancreas. Okay? And so the pancreas is what's responsible for that insulin. Specifically, that'll be your Jeopardy question for the day, is the beta cells of the pancreas make insulin. Right? So there's a few different cellular structures inside the pancreas, and specifically the beta cells inside the pancreas are what's actually making our insulin. That may be, if you're an instructor or registry or anybody likes to kind of push you to that next level of anatomy and physiology, push you a little bit further, a little bit deeper down with understanding. Instead of saying the pancreas makes insulin, it's actually the beta cells within the pancreas are specifically what's making that insulin. And so if we have a bunch of insulin, right, we have a bunch of those keys that are floating around, opening the doors in the cell and allowing that blood sugar to move from the bloodstream into the cells, right, into the cells. So as we make and produce more insulin, it's going to lower our blood sugar. Right? So that's one method of regulating blood sugar levels. Right? Remember, we have most books will give you a nice normal range for blood sugar between 80 and 120. Right? A easy way to remember that is kind of the most common blood pressure that we talk about is 120/80. And so 80 to 120 is a normal blood sugar range. Some books may say 70 to 110. You know, there's some, slight variability in there, but very commonly utilized is that 80 to 120 range for blood sugar. Okay? So if we have our pancreas, if we have those beta cells making more and more and more and more insulin, then the amount of sugar in our bloodstream is going to be going down, 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 because more of those keys are getting made, more of that insulin is getting produced. So it's opening those doors on the cells, and it's allowing that sugar to move into the cells, thus out of the bloodstream. Right? And we're checking sugar in the bloodstream, right? That blood sugar check, blood glucose check. So if our body has a way to lower blood sugar, then as with everything in the body, it also has to have a system in place to be able to do the opposite. Right? And we have to have a method that if our sugar goes too low, right, one thing we'll do is we'll be hungry, and so we'll just eat more. Right? And that'll raise the amount of nutrients in the system, raise the sugar in the system. But also what we have is another substance that the pancreas makes called glucagon. Right? And glucagon also made by the pancreas, just like insulin is made by the pancreas, although glucagon is made by alpha cells. Right? So we have alpha cells and beta cells inside the pancreas. Alpha cells make glucagon, beta cells make insulin. Right? And so if we increase the production, if our pancreas makes more glucagon, it should have the effect of raising blood sugar. And so you can kind of see this dynamic state that is going to be happening, right? As our body is monitoring, just like our body monitors how much oxygen we have in the system, our body is also monitoring that sugar level. Right? And based on that sugar being too high or too low, the pancreas will get that signal and says, hey, we should make more insulin, or we should make more glucagon, depending on which way the body wants to move the blood sugar to get us back into that happy 80 to 120 range that we would like to operate on. So with glucagon, we have to think about, okay, well, where is that sugar coming from? Right? If glucagon increases blood sugar, that sugar has to come from somewhere. And so that somewhere is why I have a little picture of the liver up here. It's not to scale. Liver and pancreas here in this picture, not to scale, so don't mistake me on that one. Liver is very large, right upper quadrant. Pancreas, a little bit smaller, kind of upper mid abdomen. Right? Actually, technically retroperitoneal space, but upper mid, liver upper right. Again, very, very large for that liver. And so we know the liver does lots of things. Right? It detoxifies the blood. It helps with the ability of the body to make clots and to clot itself over when it wants to protect itself from bleeding. Another thing that the liver does is can serve as a little storage system. Right? So if we have plenty of blood sugar, right? If we have plenty of blood sugar, right? Greater than 120, right? If we have that 80 to 120 range, so we have more blood sugar than our body needs, right? one thing it can do is, well, let's just make more insulin to lower it back down. But also, the body likes backup systems. And the body likes to have that little, in case of emergency, break glass. Right? And there's that little backup system that we have in place. So what will happen is the body will take some of that glucose that's in the bloodstream and convert it into a substance called glycogen and store it in the liver. Right? So it's a little storage container for some sugar. Right? It has to restructure it. It's not in the glucose molecular structure that our blood sugar is. So it restructures it into this substance that we call glycogen, and it stores that glycogen in the liver. And so that's just, again, when we have a little bit extra blood sugar, and our body's like, you know what? I'm going to just keep a little bit of that blood sugar, just in case there's an emergency situation later on. I'm going to keep a little bit of that blood sugar so that if my sugar starts dropping, I can use that sugar. I've got it in my system already. And so it stores it in the liver. And then what happens is when our blood sugar starts dropping, right, and our body gets that sense that says, hey, we need to raise our blood sugar. Right? The way that it raises blood sugar, we said, was by producing more of that glucagon. Right? I know it gets confusing with the glucagon, the glycogen, all these glucose, all these different terms, so you got to try to slow it down a little bit and follow it. And so glucose is our blood sugar. When we have extra of it, our body converts it to glycogen, stores it in the liver. Now, when our blood sugar is dropping, right, and our body's like, hey, we need to raise our blood sugar, let me use that little emergency storage system that I have of that sugar that I put inside the liver. Right? So the pancreas, those alpha cells of the pancreas, produce glucagon. The glucagon pulls that glycogen storage of sugar out of the liver and then restructures it back to glucose. Right? So last time our body converted the glucose to the glycogen that it needed to be to store it in the liver. And now our body's going to pull that glycogen out of the liver, restructure it back to glucose that our blood is going to carry throughout the body, and our cells are going to be able to utilize. Right? So it's that back and forth, that kind of give and take of insulin production to lower blood sugar, glucagon production to raise blood sugar. Right? So there's just constant little adaptations that our body is making to maintain a blood sugar more or less in that 80 to 120 range. Right? So that's when everything is going nice and well. Right? And we have plenty of sugar floating around in the bloodstream, and that insulin, that key to the door to open up that doorway into the cell for that sugar to actually move into the cell. Right? Because that's what we need. We need that sugar to be able to get into the cell. If it's not in the cell, it's useless for us. It's just not able to help us out if we're not able to get that sugar into the cell. All right, so it's this back and forth, but again, just one last time, the beta cells inside the pancreas are what produce insulin. And the more insulin that we have in the system, it's going to lower our blood sugar. Right. So that gets us into, kind of from the normal physiology process to get us into the actual different types of diabetes. Right? And so we have type 1 and type 2 are very common terms for it. Type 1 is also called insulin-dependent diabetes mellitus, or that IDDM acronym. It means that a patient depends on getting extra insulin and getting insulin in the body, right? Insulin injections or having a little insulin pump. And I'll show you what one of those looks like. So they're required to have those insulin injections because that pancreas, those beta cells, right, are unable to produce insulin. Right? And it can happen early in life. It can actually happen a little bit later in life, but more commonly it starts to show up earlier in life, that something is kind of destroying that ability of those beta cells. Maybe it's actually destroying the beta cells that's destroying that pancreas's ability to produce more insulin. Right? So eventually what happens is the body is producing less and less insulin until eventually it might be producing no insulin at all. Right? So they're going to be dependent on actually getting those insulin injections to make sure that they're able to utilize the sugar that's there. And the other one is type 2 diabetes or non-insulin dependent diabetes mellitus. Is those patients generally don't need insulin injections. Right? More often they may be managed by some other medications, right? Some other diabetic medications, but not insulin. It could be bad enough or uncontrolled enough that they may go on insulin at some point, but generally it's not a lack of insulin. It's what they say is a resistance to the insulin or an insulin resistance. Right? And so if we went back to our cell membrane, right, and we said we had those insulin receptors that were on the cell, right, by saying the body is resistant to that insulin, is actually what happens is a lot of those receptors kind of get destroyed, and there's fewer of them. And so if there's fewer of them, then it's going to take more effort to try to get that sugar into the cell, right? Because there's just fewer doors to get there. And so because there's fewer doors, that means we kind of start stacking sugar inside the bloodstream, right? If we had lots of doors all over the place, it'd be very easy for us to get that sugar into the cells. In this case, though, there's only a couple doors, and so all of the sugar is trying to get through just a couple doors, right? So it ends up causing some issues. So more often, like I said, you'll see type 2 get managed by some other medications. There was some different terminology that they used. They used to say type 1, juvenile onset diabetes, and type 2 was adult onset. Right? Just referencing that type 1 was typically seen earlier in life. Like I was saying, kids that got diagnosed with diabetes are more likely to be type 1. And type 2 is more adult onset and more lifestyle induced, right? Lack of exercise, poor diet, weight gain seem to be correlated with it. So we're seeing type 1 with kids and type 2 with adults. And again, type 2 more lifestyle induced. Type 1 is an actual kind of destruction of those beta cells inside the pancreas. What happened though with kind of the increasing prevalence of childhood obesity, that they were actually seeing a lot of type 2 diabetes diagnoses for kids because of lack of exercise, poor nutrition, poor kind of health picture for that kid. And so they were started to see more and more and more of those type 2 diabetes diagnoses in kids. So they really backed off that terminology of juvenile onset diabetes, adult onset diabetes, and really kind of doubled down and emphasized type 1 or type 2, or the insulin dependent and the non-insulin dependent. So the type 2 for non-insulin dependent, not medications that you're super responsible for knowing, but can help you maybe in like a national registry style question, an exam question, where you have a description of the patient, and maybe they tell you the patient's on this medication, this medication, this medication. Right? Even though it's not a medication that we can assist with, if we just have more recognition of some of those medications, then we're just more likely to kind of help us go, okay, hey, basically because they're on that medication, that's telling me that it's a diabetic patient. So maybe that factors into how I'm actually going to answer that question. Right, so a lot of these diabetes medications, other than insulin, obviously, is the more commonly talked about one. But for the type 2 diabetics on some of those other diabetes medications, or medications like glucophage is a very common one. And a lot of them have gluco in the name, or a glyco, right, or a gly, right? Again, some of those just referenced in like the glycogen stores in the liver, those sugar stores in the liver, or glucagon or glucose, right? You see a lot of those kind of root word structures actually built into the generic names of a lot of medications. So if you see like a glucophage, I believe the brand name for glucophage is a very common one is metformin. But when you see these generic names and you see a gluco in the name, it's probably a pretty safe bet that that's a diabetic medication. And the gluco is telling us the glucose, it's helping kind of clue us into it being a medication for diabetes. So these are the main two that we're going to talk about. There is also gestational diabetes, which I'll probably just reserve for an obstetrics presentation one day. But the gestational diabetes presents, just like diabetes, more so the type 2, the non-insulin dependent diabetes. But it has that same issue. It's that inability to regulate the blood sugar. Caused by, obviously, the hormonal changes that are happening when a woman is pregnant. Right? And so you may have it. Doesn't develop for everybody, but it may develop and typically resolves, before, shortly after, but typically before actual delivery of the kid, that gestational diabetes kind of resolves and they go back to, their normal, not diabetic state that they were in. Right, so that's specifically the diabetes, the disorder of glucose metabolism. Right, that's what we're saying, the disorder of glucose metabolism that shows up during pregnancy sometimes. And again, it usually resolves before pregnancy and they go back to being a non-diabetic. So type 1 and type 2 are the main ones. And it's important to really focus in on that normal 80 to 120 blood sugar range, right? Everything, like I said, with that homeostasis, everything has a little range that the body likes to operate in. So whether that range is temperature, right? Too hot, too cold, starts to cause problems. If it's oxygen, too much oxygen, too little oxygen, cause problems. Sugar, too much sugar, not enough sugar, causes problems. The important thing to understand is that whenever you have a scale like that, where your body has a range that it likes to operate in, which again is pretty much everything, when it goes low on that scale, it almost always shows up faster, right? The issues show up faster for us than when it goes high, right? A lot of this stuff, like having an appropriate amount of sugar is a good thing. Too much of a good thing can become a problem, right? But it takes a little while to get there because the body, at least initially, is very happy that it has plenty of the good stuff there. It's only when that good stuff just constantly lingers around as too much, it's too elevated, it starts to cause problems. Too low, though, the body starts getting irritated real fast, right? So I always like this. It's in a lot of the books, having a little kind of scale of blood sugar range. And I like to kind of highlight the importance of when you go low on the scale, it causes issues much faster. So if we had a 40-point drop in blood sugar, and we checked all of our blood sugars, and all of our blood sugars are 40, a lot of us are going to be confused, altered, maybe unconscious, right? We're going to be in some bad shape, right? We can't tolerate going low on that scale. So just a 40-point drop down, right? 80 is normal. We'd all be happy at 80, right? We drop down to 40, we might be unconscious. Right? Going the other direction, though, right? If we moved at that same 40 points, so we just went 40 points below normal, so let's just go 40 points above normal, and our blood sugar went up to 160, right? None of us are even batting an eye at it. Our body's going to be just fine. We're probably feeling okay, right? We probably just had lunch, right? And then our blood sugar is 160. Right? And then our body's going to adapt to it. It's going to utilize that sugar. It's going to go back down to a normal range. Right? So a 40-point drop down, we're unconscious. A 40-point increase above normal, and we're probably fine. Right? Nobody's probably actually feeling it. It's not until it really gets elevated, or it's elevated for a prolonged period of time, that it starts to cause those problems for us. Right? So when we go low on the scale, issues happen fast. When we go high on the scale, it takes a while for it to cause problems. Right? And you can use that just time and time again throughout all the medical stuff and EMT stuff for sure. Right? If our blood pressure goes too low, we'll pass out. If it goes too high, it can eventually cause problems, but again, it's going to usually take a while. Right? Chronic hypertension is an issue. Right? If we have temperature and we go too cold, we're probably going to show more signs and symptoms more quickly than if that temperature goes a little bit too high. Right? Again, oxygen levels too low, we're going to probably pass out. Too high, takes a while for too much oxygen to cause us problems. Right? So again, just time and time again, when it's low on the scale, it shows up with issues a lot faster than when it's high. So getting into hypoglycemia is kind of the easy initial one. It's the more critical one, right? And when something shows up more quickly, right? So let me just go back to our blood sugar. When we go on the low end of the range, right, that's usually where we get more involved as EMTs and paramedics, right? When we go too high on the range, because it usually takes a longer period of time, it's usually a little bit safer for us to not do anything and just recognize that there's the issue and get them to the hospital. And the hospital can deal with it more carefully than we can. They can monitor it more closely than we can in that pre-hospital setting. But when we go low on the issue, low on the scale, and it starts to cause those issues a lot more quickly, it's where we're more likely to get involved in actually treating their issue. And so on the hypoglycemia, again, definitionally less than 80, right? But most of the time they'll say, you know, once you're less than 60 or less than 50 is where you really start to actually show signs and symptoms. So if you get a scenario question, this is a good just kind of test taking tip for you. If 80 to 120 is the normal range that we're going to run with, if you have a patient situation question and they tell you the patient's unresponsive and their blood sugar is 78, yes, that blood sugar is low definitionally, that 78 is below 80, but nobody's unresponsive because of 78, or nobody should be unresponsive with a blood sugar of 78. So it's one of those ones that we have that range of 80 to 120, but we also have to think about, okay, my blood sugar is 80 or is 78, 80 is normal. Would they be completely unresponsive if they had a blood sugar of 78? Probably not. Okay. Same thing, a normal heart rate for us, for an adult, is 60 to 100. If somebody was unresponsive and their heart rate was 59, that's probably not why they're unresponsive. If 60 we would be okay with, that's normal, and 59, they're unresponsive, there's something else causing that issue. Right, so always got to think about it. Most of the time they'll give you a particularly exaggerated hypoglycemia. They'll say the blood sugar, the glucometer just says low. Right? You know it's low when the machine that we use says low, as opposed to actually giving us a number. Right? Or they'll tell you 30 or 20, you know, very low blood sugar. So important parts to recognize on low blood sugar, it's much more rapid onset, right? Minutes comparatively. Right? Once the blood sugar starts to go low, it shows up with issues much faster. Right? So hypoglycemia is a much faster onset. Skin signs, pale, clammy, sweaty, diaphoretic, some of the words, that cool, pale, clammy skin. Okay. I've heard one kind of phrase that somebody was using that says, cool and clammy, give them candy, right? And so they need sugar, right? When they have low blood sugar, they have that cool, clammy skin, that diaphoretic, sweaty skin. So cool and clammy, give them candy, right? They need sugar. They need to raise that blood sugar level. So that can be a helpful one because it's different in hyperglycemia when that sugar is too high. Now, altered mental status, right? Remember, it's a progression, right? They don't go, they're not a blood sugar of 78 and they're altered, right? It's a progression, right? As they go more and more hypoglycemic. As that body starts to sense that, you know, there's a little bit of an emergency happening, right? Heart rate will usually increase, respiratory rate will usually increase, so more likely to see rapid and shallow respirations. As it progresses, they could have a seizure, they could have weakness that could look like a stroke, it could be fully unresponsive and comatose. So those are ones that you see, but these red highlighted ones are a little bit more of the ones that will kind of clue us into it being a hypoglycemia issue. So rapid onset, cool, clammy skin, and more likely you're going to see rapid and shallow. Specifically, the shallow is kind of the key word here for us, rapid and shallow respirations. You see those things, even before you get that blood sugar check number back, we can start to think, if we know our patient's a diabetic, we're starting to make a little bit of some assumptions that blood sugar is probably low. If it started more suddenly, they have cool, clammy skin, they're altered, more likely going to have low blood sugar. Treatment for a low blood sugar, right, is for us oral glucose. Right? Oral glucose. So we have these glucose tubes. There's a variety of different ones. And this one, if you can kind of see in there, 37.5 grams is total net weight that's in there. But a lot of these, glucose 15, it's actually 15 grams of sugar that's inside of that tube. Most often we just say, give them a tube of oral glucose. Now, this oral glucose, for it to kind of work optimally, is kind of putting it inside against the cheek. Right? The cheek is highly vascular. It's a nice mucous membrane. So it kind of absorbs that sugar through the cheek into the vasculature, into the bloodstream for us to actually be able to circulate it around. Because we're putting it into their mouth like that, though, our patient has to be alert and protecting their own airway. Right? If we're at all worried about their ability to protect their own airway, we're not going to use oral glucose. It's going to be contraindicated for us. Even though we know they need sugar, we can't risk compromising their airway and causing that aspiration where they may actually inhale some of this down into their lungs, and that's going to cause a lot of damage for us. So it's one that we have to have for this. We have to have it as the patient has to have that ability to protect their own airway. So if we're looking and we're assessing our patient, we think we're going to have to bag that patient because they're not breathing too well, then we're not going to give that oral glucose. Because if they're that bad that we're thinking, hey, we're going to put in an OPA and try to assist ventilations, that's telling us they're not protecting their own airway. So we're not going to put this other substance in there. Because remember, airway for us is top priority. So we got to manage the airway. We have to manage breathing, circulation, everything else, and then we can get to treating our blood sugar. And so we have to make sure we're appropriately assessing that patient. Right? The simple kind of run-of-the-mill answer that you can use for national registry stuff in terms of medication administration is to patch for orders for everything but oxygen, right? In terms of medication use. Right? Some agencies, you may have a standing protocol, standing order that allows you to administer oral glucose, and you don't need to call the hospital. But in national registry land, we don't have protocols because we don't actually have a medical director. Right? So unless the question would be phrased, you have offline orders or standing protocols to use oral glucose, if they don't tell you that, then we have to err on that side of contact medical control for permission to give the oral glucose. On the hyperglycemia side, much more gradual onset. Right? So a lot slower. Instead of just minutes and it starts to show up, maybe it's hours, days long, where this problem has been building up and building up and building up. Right? We said initially the body's like, hey, cool, check out all this sugar. I'm going to be able to make so much energy. It's going to be awesome. Right? But what happens is too much of a good thing becomes that bad thing. But it takes a while. So it's much more gradual onset. Right? So if that scenario says they've been feeling poorly for 4 days and now they're altered today. If it's a diabetic problem, you know it's on the high blood sugar side, not likely going to be the low blood sugar side. Much more likely to have warm and dry skin, right? So cool and clammy was low, warm and dry skin is for high blood sugar. We'll talk about why they're like that. So if it was cool and clammy, give them candy. I saw warm and dry, sugar is high. Right? The sugar is high. Warm and dry, the sugar is high. They're hyperglycemic. Potentially, again, it's a progression, so potentially could show up altered mental status. Again, in emergency mode, generally we're going to get that tachycardia, the increase in heart rate. So we can't really, just based off of the fact that they have a rapid pulse, that's not really going to be enough to kind of clue us into this may be a low blood sugar problem versus a high blood sugar problem. They both will probably present that way initially. On the cool and clammy, much more likely to have that rapid and shallow respirations. On hyperglycemic, some of them, and we'll talk about it, it's coming up here, some of them, their breathing may go rapid and very deep. Right? So they may be sitting there taking very deep breaths, right? Big deep breaths, very fast, right? A high rate, right? And deep breathing as opposed to shallow breathing. So if you see that rapid and deep respirations, we're going to talk about specifically what's going on with them, but that's another one that's going to more clue us into it's a high blood sugar problem as opposed to a low blood sugar problem. Same thing, comatose, weakness, are going to be some other altered mental status changes that you may see. Again, one that can show up whether your blood sugar is low or high. So more kind of specifically, low blood sugar, rapid onset, cool and clammy skin. High blood sugar, gradual onset, and warm and dry skin. And then maybe some of that shallow breathing for low and deep breathing for high. The other one that shows up regardless of what's causing it, if your blood sugar is too high for too long, we get these 3 Ps, these 3 Ps of diabetes, specifically when their sugar is high. So most often these are things that somebody might be complaining of that they've been experiencing for a while now, and they finally decide to go to the doctor and say, hey doc, you know what? I've been doing this a lot, I've been doing that, this is how I've been feeling, right? It generally will show up with these, and it starts to support that diagnosis that they're diabetic, and that first kind of diagnosis of it is associated as that blood sugar has been climbing and climbing. Right? Whether it's type 1 or type 2, right? The issue becomes this constantly elevated blood sugar level. So the 3 Ps are polyuria, polydipsia, and polyphagia. And it's a good order for us to talk about. Right? So polyuria, right? Poly is a lot or many. Uria is referencing urination, right? So frequent urination, right? Frequent urination is polyuria, right? They're peeing a lot. And what's actually going on, which could be a whole nother day too, is talking about how the kidneys actually work. The kidneys, we know, like they're the thing that's actually filtering out our blood, and in those waste products and the things that our body decides to filter out, our kidneys filters out, it packages it as urine that we then pee out to eliminate from the body. And so one thing that can happen is our body, in an effort to deal with just constantly too high of blood sugar, it can say, we're going to store a little bit of that sugar in the liver. We talked about that one, right? Our body is happy storing a little bit of sugar in the liver, but then it's also it's sending that signal to the kidneys and saying, hey, kidneys, we have way too much sugar in the system. Can you get rid of it? And the kidneys that's filtering out that bloodstream can start to filter out some of that extra sugar, right? So we start peeing a lot to pee off, to get rid of some of that extra sugar in the system. Our body is saying, we got to get rid of sugar. We've already stored enough in the liver. We can't put any more in the liver, so we got to get rid of it from the body. And so one of the ways that our body gets rid of stuff is by filtering it out via the kidneys, and then we urinate it out. So frequent urination can be one of the body's mechanisms for trying to get rid of that extra sugar, that extra blood sugar that's in the system. Right? And kidneys filter blood. The blood is where we have all that extra sugar, so it makes sense that we're able to filter some of that out by the kidneys. And so again, a potential complaint that somebody might go to their primary care doctor and say, hey doc, I've been peeing a lot lately. Okay? And maybe that's one of those kind of clues that makes them draw some blood work, check that blood sugar, and find out that the patient has actually developed diabetes. Right? Whether it's type 1 or type 2, doesn't matter with these 3 Ps of diabetes. As long as that sugar is high, this is how your body is going to, this is one of the ways that our body is going to try to deal with it, right? Is pee off some of that extra sugar. The next one is polydipsia, right? Which is frequent or elevated or a lot of thirst. Right? They're very thirsty. And they're very thirsty because they're hypovolemic, they're dehydrated, right? Right? So they're very hypovolemic and dehydrated because we're peeing so much, right? So in an effort to try to get rid of that sugar by having us pee it out, that means we're peeing it out more, which means we're also getting rid of more water, more fluid from the system. So we get more dehydrated, more hypovolemic because of how much we're peeing. And so anytime we feel dehydrated and our body is sensing that we don't have enough fluid in the system, right, it triggers that little thirst mechanism in the brain, and we have that thought like, man, I should get a drink, and I'm thirsty. So polydipsia is thirsty, right? And they're thirsty. It's secondary to that polyuria. They're peeing so much, they're dehydrated. So now they need more water in their system. Okay? So they're thirsty. And then the last one is the interesting one, is polyphagia, okay? Which is increased hunger. And we're very, very hungry. And the interesting part is we're hungry is our body saying we need sugar, right? But we have this showing up when there is lots of sugar, right? This is a hyperglycemia thing. And our body is saying, hey, I'm hungry, we should eat. Okay? And we check the blood sugar and we see it and we say, hey, there's plenty of sugar in that system. So what's going on? Yeah. And what's going on is if we have the bloodstream, right, and we have all that sugar floating around inside the bloodstream, but no insulin, right, then the cells, right, the cells are starving, right, because none of that sugar is able to get into the cells because we don't have that insulin. Right? So even though all of that sugar is floating around in the bloodstream, the cells are sitting there saying, I'm starving, I'm hungry, feed me, we need food. Right? So it's sending that signal up to the brain saying, we're hungry, we're starving, we need sugar. And the brain's like, okay, we should eat more, right? And it makes us hungry, right? So we start eating more. But all we're doing as we're eating is adding more sugar into the bloodstream, right? More sugar into the bloodstream. And because we don't have any insulin, right, we're not getting any of that sugar to move into the cells. And so the cells are starving. Even though all that sugar is in the bloodstream, the cells are starving. So we get this increased hunger, we get this frequent urination, and then we get thirsty. Right? So it's common, it's the 3 Ps of hyperglycemia specifically. Again, these 3 don't show up if their blood sugar is low, right? Because the kidneys aren't trying to pee off extra sugar if our blood sugar is too low. So these only show up when the sugar is too high in that bloodstream. Right? So very important that you be able to recognize if they don't use the 3 P words, but they say your patient has been complaining of frequent hunger and frequent urination, and they've been very thirsty, right? You should piece apart that that's saying, that's my polyuria, my polydipsia, my polyphagia, their blood sugar is high. It's going to help you with that differential diagnosis question where they describe the patient and they ask you, what do you think's going on with them? Right? And based off of the signs and symptoms, we can figure out, hey, their blood sugar is probably elevated. Right? That's probably what's going on with them. So kind of a progression up that hyperglycemia issue, right? Because again, hyperglycemia is just kind of loosely, the definition is elevated blood sugar, right? And elevated blood sugar, depending on what type of diabetes it is, has that potential to progress to kind of a more severe, more critical issue for the patient. Okay? And so one of them that can happen is the patient progresses to this diabetic ketoacidosis, okay? Diabetic ketoacidosis, or DKA. It's the A that slides in there for it. DKA is more commonly going to show up in your type 1 diabetics. And there's going to be a different one that'll show up in our type 2 diabetics. Okay? So because in type 1, we said there's no insulin. Right? Our body has no insulin in the system, which means all of that blood sugar, right, is not able to actually move into the cells. Right? None of that blood sugar can get into the cells, right, because there's no insulin. Type 1, there's no insulin. And so our body is like, all right, well, it has a backup system and says, hey, we can't utilize any of the sugar. Right? There's plenty of sugar that's there, but we can't use it because we don't have any insulin. And so our body kind of steps back and says, okay, well, how can we make energy? Right? That's the goal. Remember, all the cells, they're trying to make energy. Right? The body needs to keep making that energy so we stay alive. Right? So in the absence of the ability to use the sugar, right, even though all that sugar is there, right, remember, this DKA presentation, it's high blood sugar. Plenty of sugar, but we can't use it. And so body says, okay, well, we can burn off fat and muscle. It makes a little bit of sugar, or makes a little bit of energy. Sorry, not sugar, makes energy. It doesn't make as much energy as if we had a good amount of sugar that we could use and a good amount of oxygen, we can make way more energy. Right? But since we can't utilize that sugar, we have to have another system. And the body says, all right, well, we can burn fat and we can break down muscle cells. And in that breakdown process, it generates a little bit of energy. It generates some waste products too that we're not thrilled about, but it's a backup system, so we're at least staying alive because our body is still able to make some energy. Not as much again, but still makes some. So what happens when you break down fats and muscle cells, right? Some of the things that you get are fatty acids and these substances called ketones. Right? And some glucometers, when you check the blood sugar, they'll actually say ketones present, or it'll just say ketones on it. It's telling us that, hey, the body is actually breaking down fat cells in order to generate some energy. And so it's telling us we're kind of in bad shape. We're in one of the backup systems that the body has. Right? The backup systems are good, but we prefer to not be there. Right? We prefer everything to be operating normally. Right? So when you break down these fats, you get some fatty acid waste products, you get ketones, right? And that's the ketoacidosis that actually starts showing up. Right? The diabetic ketoacidosis. Because of their diabetes, specifically their type 1 diabetes that they don't have any insulin, our body starts breaking down fat and makes these ketones and fatty acids. So we say it's a diabetic problem causing ketones and acidosis, ketoacidosis. That's our DKA. So again, I really want you to be able to just kind of memorize, recognize that the DKA progression is going to show up on the type 1 diabetic side. We said they become acidic. Right? We really drive into that acidosis balance in paramedic school. But for now, we can just say because we create these other waste products, these other fatty acids and lactic acids and things like that, they become more acidic. Right? And so one thing that the body will do to try to help deal with that acidosis, because remember, if we're saying we're too acidic or too basic, that's that pH scale. Right? If you go back to like some old chemistry stuff, right? pH is the measurement of how acidic or basic a substance is. And so just like sugar, oxygen, temperature, blood pressure, all those things, right? The body has a pH that it likes to operate in as well, a little range. And if we get too acidic or too basic, our body's going to start making some adaptations to try to compensate for it. So in DKA, where we're becoming more and more acidic because of these fatty acids, our body starts compensating by these small respirations. Those are those deep, rapid respirations. Right? And the reason why that works is because one of the substances that eventually can become an acid inside the body is carbon dioxide. Right? If we're keeping more and more and more carbon dioxide in our body, we're actually going to become more and more and more acidic. So since we're already acidic, to try to get rid of that acid, our body is like, well, I can get rid of some carbon dioxide, and that will help deal with the acidosis. So we start taking these big, deep, rapid respirations. We call them small respirations. These big, deep, rapid respirations is our body's ability or effort to try to get rid of carbon dioxide, to get rid of that acid. Right? So you can kind of think about carbon dioxide equals acid inside the body. Specifically, if we're retaining too much carbon dioxide, it'll really become an acid. Right? So in DKA, they get those big, deep, rapid respirations. And hypoglycemia, right? Other hyperglycemia issues, right? We're not going to have those rapid, deep respirations, specifically deep. Right? Hypoglycemia, we said, probably rapid and shallow. Other hyperglycemia issues, probably rapid and shallow, or rapid and a normal depth of breathing. But specifically with this DKA, we're going to have those deep, rapid respirations, and we call those small respirations. Right? So that's a compensatory mechanism that the body has. The body's trying to deal with the fact that it's becoming too acidic. Right? So it's trying to deal with that fact. Another sign and symptom that can show up with the high blood sugar is this fruity breath odor. Right? And there's some, rather sizable percentage of the population that can't actually smell that fruity odor on their breath. But it's a great registry question. They'll just lob you up that softball and say that their breath smells very fruity. Right? It's just the the very high blood sugar, right? And you're actually getting a sweet aroma, a sweet odor to their breath, right? So some people, if you ask them if they smelled them before, some people might say it smells like Fruit Loops is a common one that people say. I've had plenty of DKA patients. I've never really smelled it. There's a couple times where I'm like, is that it? Maybe, right? I wasn't personally able to smell it. You know, a lot of people can't actually smell specifically that odor. But again, it's another one that if they give you that scenario question and they say deep rapid respirations and a fruity odor on their breath, the answer is DKA, right? It's the only one that really shows up in. This progression, again, it's on the high blood sugar side, so it's, you know, days onset, right? It's not something that their blood sugar spiked in the last hour and now they're presenting like this. It's been this building process, usually over several days, right? And blood sugar has to get really high, right? Greater than 400, probably at a minimum, to be honest. Some of these patients, 600, 800, 1,000, right? Their blood sugar can get really, really high. Right? They'll be in real bad shape, right? The higher it gets, the more likely you're going to go to that unconscious comatose state. But at least over 400, right? And again, some glucometers, when you look at them, right, and it's got that screen will just say high, right? It's not saying hello, it's telling you their blood sugar is very, very high. Right, so a good thing when you get out there and you start working somewhere as an EMT and you find out, okay, here's the glucometer, this is where it's at on the ambulance or whatever rescue bag we carry it in. It's important to understand, like, what's the range that glucometer will actually give you a number. Does it cut off after 300 and it just says high? Right? Does it cut off after 400 then it says high? Right, and then the low end as well, right? Some of those glucometers will just say low, right? And so you want to know what is that range, so that if it's low, that gives you an idea of just how low. And if it tells you high, and you know that your glucometer only reads high when that sugar is greater than 500, then that tells you, okay, my patient has a really high blood sugar. Okay? So that's that DKA. Again, the hands down, the big one for DKA, type 1 diabetic, right? Where since they don't have any insulin, they're not able to utilize any of that blood sugar. So our body starts breaking down fat to try to make some energy, keep us alive. And by breaking down fat, we become acidic and make those ketones. And then to deal with the acidosis, our brain kind of says, hey, we should breathe really deep and really rapid, those small respirations. And the fruity breath odor one is always there. And obviously important to understand that it's several days and a very high blood sugar to get to this issue. The other one, we said if type 1 patients are going to progress more towards DKA, our type 2 patients, there we are, our type 2 patients are more likely to progress to this insane long name, hyperosmolar, hyperglycemic, non-ketotic syndrome, or sometimes you'll see non-ketotic coma, and they'll say HHNC. And sometimes you'll see HONK, honk. Oh, it's always been my favorite. But they're all interchangeable, right? The honk is honk. The honk is hyperosmolar non-ketotic. Right, so for whatever reason, they just have like 3 different abbreviations that they'll use for this. They all get used interchangeably. They're probably all in your book at some point. Always kind of, step back and make sure that the terminology that you're using matches what you're using in your class or what you're using in the book. But again, I would say, maybe have a little bit of an idea or a knowledge that your book may say HHNS, National Registry may say HHNC, and it means the same thing. Or HONK, it means the same thing. So hyperosmolar, hyperglycemic. So we said this is the other high blood sugar emergency that shows up. So it's in the name on this one. It's nice, right? Diabetic ketoacidosis. It's not in the name telling us it's hyperglycemia. This one it does, hyperosmolar, hyperglycemic. Non-ketotic, though, is telling us that we're not making those ketones. Right? In the diabetic ketoacidosis, our body is making those ketones, right? And those ketones were the that breakdown of fat and muscles, we make ketones, and that's because we can't utilize any of those blood sugars. In this one though, in type 2 diabetes, right, remember our body is still making insulin, right? But we have that insulin resistance, right? We have fewer locks for that key to actually work in to try to open those doors, right? So we have, less insulin in the system than what our body needs, right? Or insulin resistant, but our body is still making insulin. So it is still letting some of that sugar into the cells, right? Some of that sugar is getting into the cells, right? That's what we need to have happen because our body is still making some amount of insulin, right? It's still able to utilize some of that blood sugar, right? But our body has that resistance to insulin. And so what ends up happening is we're not utilizing insulin or the blood sugar fast enough for kind of our dietary input, right? How much sugar we're adding into the system. So periodically our cells are getting some of that sugar, but we're just stacking just more and more blood sugar inside their bloodstream. But because we're still able to utilize that sugar, and even a little bit of it, means our body never results in breaking over to break down fats to try to deal with the energy issue that they're having, creating energy. So our body never starts burning off all that fat because we're still able to utilize that sugar inside the bloodstream because our body is still making some insulin. Right? Remember, type 2 is non-insulin dependent. Right? They don't need extra insulin. Their body is still making some. Right? So because we never break down fats, we never get those fatty acids, and we never get those ketones. Right? So those two don't show up. That's why it's non-ketotic, because we're not breaking down fats that make the ketones. And then because we're not acidic, we're not going to have those deep, rapid, sorry for the typo there, deep, rapid Kussmaul breathing, right? Because that Kussmaul deep, rapid respirations was specifically to deal with the fact that we were acidic. We were acidic because we were breaking down fats and making those fatty acids and waste product acids. So we're not breaking down fat, so we don't get any of those acids. It means we're not acidic, so we're not going to result in that Kussmaul breathing. Right? You may or may not have a fruity odor on the breath. It says no here. You may not have it. You may have it. So a little bit kind of step off of that one. This one, similarly, very high, generally even higher than DKA. Right? If DKA is showing up 400, 500, 600, this HHNS might be 600, 700, 800, 1,000, right, for a blood sugar, right? Generally, even higher takes even longer. Right? So DKA maybe a couple days, right? Hyperosmolar several days, right? 1 to 3 days, right? 2 to 3 to 4 days, 6 days, 7 days. They've been progressing to this issue. Right? So a little bit less readily identifiable because you don't get those big outward signs and symptoms like the Kussmaul breathing for DKA. But remember, both of these are high blood sugar, the DKA and the HHNS. So both of them, you get those 3 Ps, right? So polyuria, polydipsia, and polyphagia. Right? And because we're so dehydrated, that's why we said we get warm and dry skin when our blood sugar is high. Right? Warm and dry sugar is high. We have dry skin because we're dehydrated, right? The polyuria that's making us dehydrated. So warm and dry skin will show up both for the HHNS and as well as the DKA, as well as just the hyperglycemic patient that hasn't progressed to one of these more critical emergent situations. So all of the hyperglycemias will start to present with those 3 Ps. Right? DKA will start to present with that acidic state and the Kussmaul breathing because our body is breaking down the fats. Since we're breaking down fats in DKA with those type 1 diabetics, right, our body is burning and breaking down the fat and the muscle, right? You're more likely to have weight loss with that type 1 diabetic, DKA, more likely to have weight loss. Right? Another one with hyperosmolar on type 2, right? Remember type 2 we said is usually a little bit more lifestyle induced, lack of exercise, poor nutrition, those kind of big ticket ones. So you're more likely to have weight gain. We're not burning down fat to try to make energy, right? So because we're not burning down the fat, we get the weight gain associated with this one. So it's another variable that can help you kind of differentiate between these two progressions of type 1 and type 2. All right, so hyperglycemia treatment, right? The treatment is primarily geared at lowering their blood sugar, right? The issue is that sugar is too high. So we have to lower blood sugar, right? So they need likely that insulin, if it's particularly an emergent situation, right? Maybe they need some other medications to do it, like that glucophage, right? That was one that we said. Glucophage was another diabetic medication. It's not insulin. It's a different type of medication. The insulin, though, has to be very carefully done in a very controlled manner. Right? So if the patient has their own insulin and we check their blood sugar, we can't help them with that. We can't administer it. That's not on our list that we can patch for medical orders. As a paramedic, I can't assist somebody with their insulin either. So it's not even the BLS, ALS thing. It's just something that we don't do, right? It's too individualized, right? Everybody's on their own particular type of insulin, their own scale of insulin. Some insulins are rapid onset, others are delayed, right? More slow onset. So it's very individualized. So it's something that needs to be very carefully done inside the hospital. So for us, it's mostly recognition that their blood sugar is high and that they need to get the help in the hospital, right? Whether it's insulin or some of those other medications. Because of all of the fluid loss, right, they're likely going to be needing fluid. Right? We said because of all that polyuria and they're peeing so much, they're getting rid of so much fluid that we need to probably give them fluid. Right? But that's out of our realm as EMTs. As paramedics, we can do it. But as EMTs, we can't. So it's another one, the recognizing that they need fluid fixed because we know that they were dehydrated. Usually with that dehydration is also electrolyte imbalances, right? Electrolyte imbalances that start to show up as well. So it's another big aspect of it is monitoring the fluid and the electrolytes and also dealing with the insulin, right? And dealing with specifically lowering that blood sugar. So this picture here, I pulled one just to have is an insulin pump, right? Some people still do the shots, like little injections that they do generally into their abdomen. And that's the insulin that then gets absorbed into the system so that it'll get circulated throughout the bloodstream so our body can actually use the blood sugar that's there. Others have kind of this little adapter implanted thing in their abdomen, or some people you'll see that little spot on the back of their arm, right? And hooked up to a pump like this is one example of one. And that pump is just slowly throughout the day, right, administering that insulin for the person. Right? So it's a very compliant diabetic patient that they're monitoring their own blood sugar regularly, appropriately understanding that they need insulin. Right? And again, because it's an insulin pump and it's insulin that's being administered, more likely, again, that they're type 1 diabetics. Right? Because again, type 1 diabetes is insulin dependent. They depend on the insulin to be injected so that they can actually keep utilizing sugar and not develop an issue. Right? Type 2 diabetics, right? More likely to try some other medications first. It could be bad enough and progress negatively enough for that person that they could start insulin for a type 2 diabetic. Usually they'll try some of those other diabetic medications that help to lower blood sugar. A lot of different types of those medications that all work very differently, but again, have kind of that same goal of the body's ability to better utilize the sugar that's present, right, and the insulin that the body is still making as a type 2 diabetic. Also, since it's generally much more lifestyle induced, right, then some lifestyle changes are always recommended, right? Checking that diet, getting some more exercise, right? Trying to better manage their overall health state. That way can go a long way for helping those type 2 diabetics as well. But if the lifestyle stuff's not working, the lifestyle changes aren't working, and they'll try these medications. If those medications aren't working, that patient's still having issues, then maybe they'll get over to insulin as an issue. But again, in that kind of emergent situation, right, they're going to need the insulin administered in the hospital. Right? Generally, these patients are probably going to be admitted to the ICU so they can very carefully and gradually lower that blood sugar. They're going to replenish the fluid since they're dehydrated, right, because of all those polyuria that they're doing. And because they're dehydrated, there's that potential that the electrolytes are very imbalanced as well. And that's another thing that has to be very carefully corrected in the hospital. So again, most of our treatment gets directed back towards just initial ABC management and checking a blood sugar and recognizing that that's what is going on for that patient, that they're having a diabetic emergency. It's too low or it's too high. Then on the low side, we said when we go low, we're more likely to get involved on specific cares. And so if it's too low, we have that potential to do oral glucose to try to raise the blood sugar that way. But the big piece of that equation is certainly making sure that the patient has the ability to protect their own airway. So if they're really altered or unconscious, then we're not going to do that oral glucose because we worry about that aspiration happening. All right, so let's do a couple questions. We'll wrap up our day on this. I'm going a little longer today, but that's a big topic. Right? There's a lot going on with this topic, so we want to make sure that we can kind of appropriately take a look at all this stuff. So here's our question. Your 68-year-old patient is confused and slurring their speech. His wife states it started suddenly 30 minutes ago and he has a history of diabetes. His vitals are blood pressure 118/74, heart rate of 118, respiration's 12 and non-labored, SpO2 is 94%, skin is cool, pale, and clammy. Based on this presentation, you suspect hypoglycemic emergency, diabetic ketoacidosis, hyperglycemia, hyperosmolar hyperglycemic non-ketotic coma. Okay. So kind of like we've been saying, right? A few ways to take a look at this question. They're not giving us a blood sugar because that would help too well. Okay. So we have the skin is cool, pale, and clammy, right? And that's one that you can remember. If you know that our answers are all diabetic answers, if we've got cool, pale, clammy, right, that was one of those findings of a low blood sugar, right? Cool, pale, clammy, give them candy, right? We need to raise their blood sugar, right? So if you just recognize that that cool, pale, clammy shows up with low blood sugar, okay, that would put A as a great option. Okay. Hyperglycemia is obviously out. Even if you didn't really remember what this hyperosmolar hyperglycemic non-ketotic coma is, you could at least, again, recognize that there's hyperglycemia in that one. Okay. So purely just by recognizing skin is cool, pale, and clammy, and you know it's low blood sugar, you're at least down to A and B. If you didn't remember that B, DKA, is also a high blood sugar problem. But C and D both have the word hyperglycemia in there, so you can rule that one out. Okay. And then the other big variable of this one is we says it started suddenly 30 minutes ago, right? And a more rapid, sudden onset further helps support hypoglycemia as the issue, right? DKA is a high blood sugar problem. It's slower onset. Hyperglycemia is high blood sugar, slower onset. Hyperosmolar hypoglycemic non-ketotic coma is slow onset. All right, so none of those other three, B, C, and D, didn't develop in the last 30 minutes. Right? Low blood sugar did. Right? So it's a good kind of differential diagnosis question where they give you some vitals and some signs and symptoms and kind of an onset timeline. And then they ask you, what do you suspect is going on with your patient? Right? So it's being able to recognize the signs and symptoms that they're giving you or painting the picture of a low blood sugar problem for that patient. Right? So a hypoglycemic emergency is what shows up here. All right, question number 2, your diabetic patient is presenting with altered mental status, rapid and deep respirations, and a blood sugar of 650. You should do what? A, assist the patient with their insulin. B, contact med control to administer oral glucose. C, promptly transport the patient to the hospital. And D, attempt to ventilate the patient at a slower respiratory rate. This is a good question. We have a documented very high blood sugar. They're altered, right? So really bad. We have rapid and deep respirations, which hopefully you guys would recognize. Those rapid and deep respirations help support that DKA patient. And again, just one more time, I'm going to remind you, DKA patients show up from your type 1 diabetic patients. So it's a hyperglycemia issue. So we know the need that they have is to lower that blood sugar. And amongst other things, they got to lower that blood sugar. Right? However, we are not able to assist them with their insulin. Right? Even though we know medically, pharmacologically, definitively what they need, at least one of the things that they need is insulin to lower that blood sugar. We cannot, it's out of our scope of practice, it's out of our realm. We cannot assist them with their insulin. Even though the patient may, in this case, they're altered in the scenario that I wrote, but if our patient was conscious, we still can't assist them with their insulin. Even if they say, this is the normal amount of insulin that I take, we still cannot assist them with their insulin. B, contact med control to administer oral glucose. While administering oral glucose is going to raise their blood sugar, we already have high blood sugar, so that's out. C, promptly transport the patient to the hospital. Nothing wrong with that answer, right? We've got an altered mental status, deep rapid respiration, hyperglycemic patient. We've got a person in critical shape. So we definitely need rapid transport to the hospital. There's no question about that. Let's take a look at D. Attempt to ventilate the patient at a slower respiratory rate. So there are times that we can ventilate patients because they're breathing too fast. Okay? If they were conscious, we might try to coach their breathing down, depending on why they were breathing too fast. In the context of this DKA diabetic patient, though, we got to remember that those deep and rapid Kussmaul respirations, remember that's the word, whoops, sorry about that. Remember that's the word, is these Kussmaul respirations. I lost my pen, sorry about that. Our Kussmaul respirations are those deep, rapid respirations. That's a compensatory mechanism that the body has, right? So we don't want to try to ventilate them at a slower rate because that would be us ventilating them with like taking away that compensatory mechanism, right? That's the body is trying to deal with that acidosis, right? So bagging them at a slower rate is going to be working against the patient. It would actually be, it would be making that person in worse shape, right? So we don't want to slow down those respirations for the type 1 DKA diabetic patient. So D is going to be out. So C is going to be that answer that we will use, right? Just rapid transport to the hospital is going to be the most appropriate for this patient. And the third question here, right? Your patient is responsive to pain, has gurgling respirations, and cool diaphoretic skin. Vitals, blood pressure 98/58, heart rate of 124, respirations 8 and shallow, SpO2 90%, and blood glucose is 38. You should. Remember, anytime they say you should, you can add, you should do what first? That's a, generally I say don't add stuff to questions that's not there, but if they just leave it hanging there as you should, the follow-up to that is you should do what? And if you like a lot of the answers, then you got to say you should do what first. And so we got to kind of work our way through all of these things. So we have a altered patient. Hey, my pen's back. Responsive to pain. We've got gurgling respirations. We're not happy about that. We've got cool diaphoretic skin, which is, telling us something, right? It may be shock, poor perfusion. It may be hypoglycemia, right? Cool and clammy, give them candy, right? Now we got a blood pressure of 98/58, right? So we're getting that hypotensive territory. We're getting an elevated heart rate, am I right? Respiratory rate of 8, I'm not thrilled with that number, and I'm really not happy about that word shallow. That's one that I tell you, just take to the bank. If you see that shallow word that's telling us they're not breathing adequately, and bagging that patient is one of the things that we will do for this patient. Right? It may not be the thing that we do first, but we will do it. It has to be on that table. Right? We've got an SpO2 of 90%. I'm not happy about that one either. And a blood sugar of 38 is very, very low. That's why I'm not happy about that. So I'm not happy about a lot of stuff going on with this patient. They're very altered, gurgling respirations, cool, clammy skin, hypotensive, slow and shallow breathing, hypoxic, and hypoglycemic. A lot of negative things. Okay. So contact med control to administer oral glucose is an answer. Assist ventilations with a bag valve mask device is an answer. Suction the oropharynx, insert an airway adjunct is an answer. Start rapid transport immediately is an answer. So we can look at those and we can say, dang, I like all of those things. So we got to kind of slow down and kind of go through them a little bit. Because at first glance, like, okay, they got a low blood sugar, so let's raise the blood sugar. They're breathing slow and shallow, so let's bag them. Gurgling respiration, so let's suction. Rapid transport, absolutely. This person's very altered. Right, so we like all 4 of those at first glance. So let's work through them. Contact med control to administer oral glucose. Oral glucose, absolutely, we're going to want to administer for that low blood sugar. Okay. But if they're only responsive to pain, and the breathing slow and shallow, and these gurgling respirations, I don't feel good about that person's ability to protect their own airway. And we said if they're very altered and can't protect their own airway, I don't even need to bother contacting med control to ask if I can give them oral glucose. Med control is going to say, are you out of your mind? No, don't put anything in their mouth and get them here as quick as possible. All right, so we're not going to give, we're not even going to try to give or try to ask to give oral glucose if they're responsive to pain, gurgling respirations, slow and shallow respirations. Just not going to happen. Assist ventilations with a bag valve mask device. Again, like I said, if you see shallow breathing, specifically slow and shallow, and certainly in the context of hypoxia and altered mental status, all of those things fit the bill. But when you see shallow breathing, assist ventilations is a great, great answer. Right, so I really like answer B. C, suction the oropharynx and insert an airway adjunct. Okay. Gurgling, right, that magic word of gurgling says we've got something in the airway. Right? We've got some sort of secretions, fluid, vomit, blood. We don't know what it is yet until we take a look inside and see. Right? But gurgling is telling us we've got secretions, we've got fluid, we've got vomit, we've got something up there. Right? And nausea vomiting is a common side effect or complication or symptom that shows up with the hypo and hyperglycemia emergencies. Right, so gurgling respirations, I really like suction the oropharynx, and I was already concerned about their ability to protect their own airway. So inserting an airway adjunct, I really like C as well. And D, start rapid transport immediately. We have a patient who is responsive to pain, gurgling respiration. It's a very altered, very critical, very sick patient. I really like rapid transport as well. Right? So this is what happens, and it's why a lot of people can get frustrated with National Registry, is because they'll say, I'm going to do all of those things. And if I'm going to do all of those things, like, what is Registry trying to do? They're trying to trick me. They're trying to stump me. They're messing with me. And I'm going to do all of these things. I like all these things, except A in this case. We're not going to do A. That one we're for sure not going to do. But we'll bag this patient. We'll suction this patient. We'll transport this patient. No question about it. And so sometimes that happens, and that's where people get stumped because they don't know that you should, part of the question, you should means, means you should do what first. Yeah. You should do what first is that National Registry skill sheet, the BSI, the scene safety, the nature of illness, call for ALS, consider C-spine, right? How many patients do I have? All of those things. And then our general impression and our chief complaint, level of consciousness. Right? Work your way through all these things. That was actually a little bit up in here. So general impression, then our chief complaint level of consciousness, and then we're going to assess and deal with the airway. And then we're going to assess and deal with breathing. And then we're going to assess and deal with circulation. And then we're going to make our transport decision. Right? And then we're going to do our sample medical history, right? And our OPQ or ST questions. And then we're going to do our physical exam. And then we're going to form, based off of all of that information, a differential diagnosis or field impression. And after we've done all of that, I've assessed all of these things, I've dealt with my emergent ABC issues, I've made my transport decision, I've asked all my sample history questions, I've done my physical exam, here's what I think is going on with my patient. And then, based off of that, we're going to do any other special treatments for that patient. So if it was appropriate to give oral glucose to this patient in this question, which it's not, but if it was, oral glucose would be down here in these other treatments, right? What I also missed in here is vitals, right? The vital signs, part of that physical exam, get your vitals. Right? So it's after all of that, we'll do those other things, right? So in this case, we said, I'm going to assist ventilations. I'm going to suction the oropharynx and insert an adjunct. I'm going to rapid transport. Right? You go back to your National Registry skill sheet and say, one of my answers is A, right, is an airway thing. One of my answers is dealing with breathing by bagging the patient, and one of my answers is to start rapid transport. So you should do what first is going to be C, suction the oropharynx and insert an airway adjunct. Right? I have to deal with A first, and then I'm going to go to B, and then I'm going to go to C. Right, or D rather, right? But I have to deal with airway first, right? Airway is first. Right? So gurgling respirations tells us I need to suction. Shallow and slow and hypoxia for the breathing tells us I need to bag the patient. This whole critical situation picture that they're showing me tells us I should be doing rapid transport, right? So which one am I going to do first? Well, I'm going to start at the top. And at the top of my list is airway. Right? So that's where we're going to go. So this is a phenomenal style of registry question, because some people will say, is like, well, there's more than one right answer. There's only one definitively right answer, or there's only one, we'll say, sequentially right answer. Right? In that, which one of these are we going to do first? Right? And you'll get questions, I promise you, you'll get questions on exams, on National Registry, and whoever it is, and all four answers are definitively good, valid answers. Right? So you got to put those answers in order. Right? If all four of them are good, you got to put them in order. Right? And order matters. Just remember, everything about National Registry is they're asking us to evaluate, assess, treat patients as if we were completely on our own. And even though we know that's not the case, EMS is a team atmosphere and everything, we know it's not the case. We know we need to be dealing with things together. Right? Registry has us deal with it on our own. And on our own, we have that medical assessment skill sheet that says I'm going to do this, then this, then this, then this, then this, because I'm on my own. Right? So when you're answering this question on your own, you're going to deal with the airway first. Breathing first, second, transport third. Right? That's the way to look at those. All right. So that is a lot of diabetes talk, right? So I want to kind of wrap it up today with this one. And an hour and a half today. All right. So next session that I'm going to do, I'm going to focus in on working in cardiac arrest, right? Dealing with that BLS resuscitation, a little bit of the choking patient stuff. If you're using kind of one of the main common EMT textbooks, my name's actually on the inside of that textbook. I served as a reviewer for this book. But if you're using this one, it's one of the chapters is actually BLS resuscitation. So it's all about our CPR ratios and dealing with cardiac arrest. So it's going to be a good review of that one. It's another just foundationally critically important thing that you should focus on and understand. So that one I'm going to do next Friday, not this Friday, next Friday. so a little bit longer of a session, or a little bit longer of a time frame. I'm going to do it an hour later than I did today. Right? So I'm going to do it at 3 p.m. Pacific, which is where I'm at, Arizona time, 6 p.m. Eastern. I always kind of try to put a couple up there, but when in doubt, just Google, what time is it in Pacific time right now, right? If you enter in a different time zone. Arizona's goofy. We don't do daylight savings time. We just stay the same all the time. So 3 p.m. Pacific time is what we'll be doing next Friday, the 15th, on resuscitation. And I always like to leave you guys with a little study habit builder, a little recommendation, a little kind of coaching feedback part. So on this one, I put Eat That Frog, which is actually a book. It's a concept that's out there. It's very good. And it really is saying, if you knew, right, the concept behind it is, if you knew every single day of your life that you had to eat a frog, right, and every single day, no matter what, you were going to be forced to eat a frog, then you should do that thing very first in the day. Right? So whatever you like least, do it first in the day as much as possible, or as early in the day as possible. Because the more you push it off, the more you procrastinate it, the more it just is this lingering distraction all day long of, oh my gosh, at the end of the day now, I'm going to have to eat that frog. And all day long you're thinking about it. I don't want to do it, but it's still there. I don't want to do it. Right? So we can use that same concept with studying and say, if you have a particular type of studying that you don't like to do, but you know you need to do it, you should do that type first, right? In its own way, we're kind of saying, let's get it out of the way, right? Get that part out of the way so we can do the more enjoyable stuff, right? And we can really focus and enjoy the stuff that we like to do by doing that least favorite part first. Now, if your least favorite part is all studying, you just hate studying entirely, well, then you have to pick, of all the different things that you need to study, glossary terms, reading, homework assignments, workbook assignments, whatever it is that you do, right? If you don't like doing any of them, then at least kind of step back and say, well, if you don't like doing all of them, which one do you like doing the least, right? Or which one do you hate doing the most, right? Whatever your least favorite, most painful aspect of studying is, get that part done first, right? I know we, in my programs, we used to use the big physical paper workbook, and every student hated it, right? Eventually we stopped using it for different reasons, but every student I talked to, they said, I hate that workbook. I don't like doing it. I feel like it's a waste of time. And at the time, it was a graded component of the program, so they had to do it. And so I'd recommend to them, I'm like, well, get it out of the way first, right? Get it out of the way so you don't have to worry about it. You don't have to think about it. And then the other stuff that you like to do more, the glossary terms, the flashcards, the crossword puzzles, the diagrams, whatever it is, the reading in the book even for some people, or listening to an audiobook, right? You'll be able to focus more on those things that you enjoy if you get your least favorite part out of the way early. Right? So eat that frog, right? Do your least favorite part of your studying first, and then that way you'll feel better and be coming into the rest of your studying with a more positive mindset and a more focused attitude and energy level, and you'll actually get more out of that studying by getting the least desirable part out of the way first. So that's it for this session. I'll kind of wrap it up here and say thank you guys for logging in today. I'm going to get the video processed and up online like normal. So don't hesitate to reach out. Let me know what you think about it. I certainly appreciate it. So I'll see you all later. Hope to see you again on the next session, and certainly interested. If you have any questions, you can shoot me an email. It's andrew@medicmadeeasy.com. Shoot me an email if you have other topics that you're struggling with or questions based off of today's. Like I said, if you didn't quite catch anything, if I was going too fast at any point, this video will be up online, so you'll be able to access it that way and be able to get in and then kind of focus and re-listen to it over and over again will all help. So if you don't have anything else, I'm going to go ahead and sign off for now. And again, I appreciate you logging in. I really do. And I hope to see you again in the future.